I want to discuss today the process of devising guidelines. I am employed by the Scientific Institute of Public Health and receive funding, European funding, funding from the International Agency for Research on Cancer, and also Belgian funding. The objectives of my presentation is, there are 2 points. The first point is the question, how should we assess evidence on efficacy and effectiveness of new versus existing screening management options? And if we have that evidence, how can we translate that evidence into guidelines? How can we recommend new screening methods? What is the strength according to the level of evidence that we have? I can start at 2003. An important meeting took place at the European Council, and all ministers of health endorsed the scientific consensus into a political consensus, which stated that there is evidence that organized screening can reduce co-specific mortality from 3 cancers: breast, colon, and cervix. For the cervix, screening with a pap smear, starting somewhere in the range 20 to 30, up to 60 at a 3 to 5 year interval. A strong point was made about the fact that screening should be offered in organized programs. The participation of the population should be optimized, as well as the quality of the screening and the follow-up of screen positives. And all those processes and the impact should be monitored. And policies should be defined in accordance with evidence-based guidelines. Such a guideline was published, the 2nd edition, in 2008, based on the evidence available of 2007. In that guideline, we recommended HPV testing in 2 applications: triage of ASCUS and follow-up after treatment of CIN. HPV primary screening was not recommended at that moment. We wanted to wait for a further level of evidence. We knew already it was more sensitive, less specific, but we wanted to observe in a second screening round, in randomized population-based trials, at least less CN3+ in the HPV arm compared to the cytology arm. And this was not yet available in 2007. Okay, now a bit about the principles of evidence assessment. The first step in evidence assessment is listing a series of clinical questions that gives guidance to health professionals. And this list should be discussed among experts, members of professional societies, public health experts, and when this list is finalized, each question should be decomposed in its PICOS components, where P stands for the population or the group of patients where the clinical intervention should be applied. The I stands for the type of intervention which is discussed. C, the comparator, so I, the new method, C, the comparison group, O, the outcome or the endpoint, and S, the type of studies. So once this is done, the PICOS can be translated in a search string, and this can be submitted in Medline or other bibliographic databases in order to retrieve the literature. Then from each selected study, the evidence have to be summarized. First of all, existing systematic reviews and meta-analysis should be identified in order to avoid to replicate previous work. If necessary, new systematic reviews or meta-analysis can be conducted, or as an alternative to advance more rapidly, because making a meta-analysis requires a lot of time, you can do mini reviews. And then a process of evidence grading starts, where the evidence is graded taking into account the design of the studies, the quality of the studies, the consistency of the findings, and the type of outcomes addressed. And according to this graded evidence, graded recommendations are formulated. Now, a bit about the study type. We can distinguish a high level of evidence, which can be derived from consistent findings from several multiple trials, which can be pooled or not. A lower level is just one randomized trial, and then I go further to lower evidence, a prospective cohort study, a retrospective case control study, case series, and finally, of course, the lowest level of evidence comes from expert opinion. Now, there are different guidelines developed recently over the last 10 years in the literature, which help us in checking the different quality or design parameters which allow us to judge the evidence from a paper. These guidelines are all published in very high impact factors, BMG, YAMA, Annals of Internal Medicine. For randomized controlled trials, we have the CONSORT and the Quorum guidelines. For observational studies, the STROPE and the MOOSE. Diagnostic status, the START and the QUADAS. And for meta-analysis, for conducting meta-analysis or judging the quality of meta-analysis, we have the PRISMA and AMSTAR guidelines. I invite you to consult the literature to have more information about those very important guidelines. Now, a few words about the outcomes of studies, which is also a component of the evidence assessment. We can put on top reduction of co-specific mortality. At the next level, reduction in morbidity of clinically relevant morbidity for cervical cancer, let's say incidence of stage 1B+. Reduction of incidence of cancer overall, also including the microinvasive cancers. A further level of evidence is when we reach the outcome of reduction in incidence of CN3+, or increased detection of CN3+, CN2+, and a very low level of evidence can be derived of evidence which show increased test positivity, which slightly increased but preferentially similar or hardly reduced positive predictive value. The next component in evidence assessment is the assessment of the external validity. And this can be assessed by looking at the heterogeneity in study outcomes, the reproducibility of tests by repeating by different assessors, and the representativity of the study setting described in the papers for the clinical routine practice. Now, according to the level of evidence assessed, taking into account the different dimensions of quality, we can formulate strong or weak recommendations. An A recommendation is a strong recommendation to apply a new method. B is it is simply recommended. C is a neutral recommendation. It is accepted, but there is no strong favor in applying or not applying. D, we preferentially should not apply the new method. And E, we certainly should not do it. And the strength of recommendations are formulated after having integrated a matrix of the level of evidence dealing, taking into account the outcome, the study type, the study quality, and external validity. Now, a process of evidence assessment starts with a listing of questions. And here I have, just as an example, made a part of our list of questions for our next European guidelines. First question is on accuracy. Cross-sectional studies. What is the accuracy of HPV versus cytology versus the combination to detect cancer precursors? A more important question is, can HPV screening reduce the burden of pre-cancer? And this we should define at a CN3+ level and cancer. What is the amount of overdiagnosis? This means diagnosis of regressive lesions associated with HPV, cytology-based or combined screening. If we have evidence for one test, what evidence we have to generate for other tests, other HPV DNA tests? What are the minimal requirements for other tests is also an important question. And we have answered that. We have a publication. I refer to the Meyer guideline published in the International Journal of Cancer in 2009. Some questions which will be addressed by other speakers is at what age we should start screening? At what intervals? When should we stop screening? I go further. What is the accuracy and predictive value of different possible options to triage HPV positive women? We can also do self-sampling and do HPV testing on it. So what is the accuracy of the self-sampling compared to clinician-based sampling if we do use an HPV screening test? Is HPV testing as a primary screening method also cost-effective? And we balance the outcomes against economical outcomes. Now, we have done most of the work, and many others have done it as well, and we can conclude on HPV testing and primary screening that it is more sensitive, less specific than cytology to detect precancer. But the accuracy is less variable. It's quite consistent, and this reflects higher reproducibility. Combined screening, HPV plus cyto, is not more sensitive, but it is less specific. It generates costs and adverse effects. We have now consistent evidence from randomized trials that there is less entry in the second screening round among women that are HPV negative baseline versus women that were in the cytology arm, cytology negative. And this was the piece of evidence we needed to switch in European guidelines from cytology to HPV screening. We can use HPV testing on a self-sample. By HPV testing, we gain lead time, and this allows us to extend the interval for at least 5 to 7 years. But it's easy to say for an epidemiologist, it's not so easy to implement that. And therefore, in Europe, we recommend already for cytology screening an organized setting, but a fortiori, we will recommend that even more for HPV screening, because of its lower cross-sectional specificity, we should not apply it in young women, and we have to adhere to strict triage guidelines. Now, the reduced specificity of HPV screening can be handled by not starting too early and by applying a triage protocol, and we certainly will discuss at the other presentations the different options which are for the moment cytology, typing for 1618, P16 immunostaining, RNA testing, repeating the test and looking for type-specific or just high-risk HPV persistence. We cannot address everything in the assessment of trials. We have to complete our knowledge by modeling, and we also have to put it against costs. And therefore, we need the cost-effectiveness modelers, the health economists, which also will balance the health benefits against the harms and costs of screening and follow-up of screen positives. When we want to implement new policies, we cannot derive all consequences and possible impact from randomized trials. The real-life implementation is different, can be different, and therefore it is good to start with pilot implementation and look for other aspects not addressed in trials, such as adherence, compliance of the population, the quality of real-life implementation of testing and triage, and so on. And when everything goes right, we roll out nationally. An interesting tool is also the randomized health services studies, where we do not randomize, we do not apply research methods, but we randomize health services, age groups or cohorts, and without substantial cost, we come to real-life estimates of impact and process parameters. Now, to conclude, new screening policies should be evidence-based. The assessment of the efficacy from trials should be done according to internationally agreed criteria. Real-life effectiveness should also be assessed. The implementation should be set up in such a way that it can be easily evaluated. And most important, besides the choice of the screening policy, we need a well-organized system with a monitoring system to see if our new guideline is implemented well. I think this was my last slide. So we will discuss now during the next presentations at what age should we start, at what interval should we screen, when should we stop. We will discuss the guidelines in different parts of the world, and near the end we will discuss future policies where we combine screening and vaccination and look for the evidence we have today on molecular screening, and near the end we should come to conclusions. So, dear co-chair, dear colleagues, I thank you for your attention.
Thank you, Marc.